just want to thank you all for coming. Especially I wanted to thank Dr. Barbara and Dr. Bakunis and Dr. Cooper, who kind of helped set all this up to get our amazing speaker, which Amanda is going to tell you about in a second. You know, I think that this is kind of a culmination of a lot of our efforts, you know, to try to bring, you know, improve our ECMO quality, both in our department at Memorial Hermann, that we've worked on the last year to get more eCPR cases, to identify that, and then to try to work on our pre-hospital ECMO. And I want to say I appreciate Dr. First coming out with, you know, we have a lot of our HFD folks that kind of are really excited to hear our speaker. And, you know, we're working on creating our own pathway within Houston, try to bring, you know, do eCPR. And we thought, what better way to bring, you know, eCPR to Houston than to hear from the person that did the first eCPR in the United States. And so with that, I want to turn over to Amanda to kind of introduce our speaker.
Thanks. Hi, my name is Amanda Humphries Ventura. I'm an EMS physician here in the Department of Emergency Medicine at UT. It is my distinct honor this morning to present our guest, our visiting professor, Dr. Darren Brody. He got his medical degree at the New York College of Medicine. He completed residency at UCSF Fresno, and he is faculty at the University of New Mexico, where he is now full professor of adult and pediatric emergency medicine, as well as anesthesiology. He's also faculty and the International Medical Director for the Difficult Airway course, and is medical director for a multitude of EMS agencies in and around Albuquerque, including what I would venture to say is his favorite medical direction gig as UNM Lifeguard Air Emergency Services. Beyond these and all of his many more academic achievements, I am fortunate enough, after completing a fellowship at UNM, to also call him mentor and friend. And so without further ado, Dr. Darren Brody.
Thank you. Well, thank you all, and thanks for having me. And it's great. I know there's some people online as well, and it's great to have some EMS folks here. We did almost exactly the same thing going back about 5 years when we were trying to look at starting a field ECMO eCPR program, and we brought in folks from Europe that were doing doing this to kind of have these kind of discussions. And I think this is fantastic that you guys are taking this approach to the project. So and first of all, I have to recognize that this project and what we've done wouldn't have happened without the collaboration and support both of my institution, but also Albuquerque Fire Department, who have been really equal partners in this whole crazy venture. So just real quick, you know, I'm from this place, which most people know for the balloons. We also have these things called mountains there, which is nice. And I know you guys have a fantastic fellowship here. If for some crazy reason you would want to leave Houston, I have to do the shameless advertising for our fellowship program. We have, you know, all the components. We've been doing this for a long time, and we take 3 fellows a year, and it's a good time. So hopefully there's some aspiring EMS people wherever you go to fellowship. I think it's been a great career path, and I hope people are heading that way. So, but we're going to jump into the topic, and I'll hopefully leave time for questions as well, because that's probably where the most important part of this is, in the questions. But so kind of the things we're going to talk about a little bit, and we won't spend much time on what is ECMO eCPR, but there's probably a few learners in the room that might have a different background in this. Really talking about why we'd want to do eCPR, why we'd want to do pre-hospital eCPR, what we call pre-hospital ECMO, PECMO, and kind of some approaches, both our approach in Albuquerque to this, and some other approaches around the country and around the world to the logistics that are involved. And disclaimer up front, we can claim that we were first in the Western Hemisphere, but we haven't done a whole lot of cases. We got shut down by COVID, and we're just in the process of restarting our own program. Now, it's exciting to talk to this group here because you all have a track record of recognizing that you have to leave the hospital, which not every place recognizes that. So you both have a long track record of physician field response, and you also have done things like a stroke ambulance. So the leap to pre-hospital ECMO is not nearly as big here as it is in some other places that I go and talk. And a few assumptions that we'll start with before we get into the meat. We have to assume that there is a benefit to eCPR in the right patient, and we can talk about what the right patient is, and that may be a whole nother discussion. And if there's a benefit, earlier is better. And I talk about this all the time. eCPR is good, but ROSC is better. And even though some of the patients that we get return to circulation go on ECMO for cardiogenic shock and for stabilization through the cath lab, at the end of the day, we can't beat ROSC. And so we can't get so focused on eCPR that we completely lose sight of the rest of our resuscitation. And from our perspective, and I know you all are looking at doing research on this, which is fantastic because we need more research, but we don't consider the concept experimental. In our minds, we're just taking what we do as standard of care for cardiac arrest patients in our emergency department and taking it to a population that wouldn't otherwise have access to it. So we didn't do it from an experimental perspective, but I think the more research that we can get, the better. So, and you guys can stop me at any point and we can keep this super informal, but just to make sure. By the way, there's this thing on this screen that says no microphone detected on your system. I don't know if that's an issue or not, but we did a sound test before, so hopefully that's not an issue. All right, so real quick, what is ECMO? Probably everybody in the room is familiar with this, and there's some people in the room that are experts in this, but so extracorporeal membrane oxygenation, extracorporeal life support. This can be a few different things. So this can be support for the failing lungs, and that has been, unfortunately, our existence through the last few years of COVID. And I think it took us offline, really, because we had, every circuit in the hospital was being committed to this, and that's a whole nother discussion. We breached that a little bit over drinks last night. But basically, if you're not familiar, just the general concept, we're taking, in this case for VV ECMO, we're basically taking a large part of the cardiac output out, putting it through an oxygenator, putting oxygen in, removing CO2, and putting it back into the venous circulation. And so basically taking care of what the lung can't do, which can be done through a variety of different single or double catheter cannula systems. There's also support for the failing heart, which I suspect, I was only downstairs for a few minutes, but I imagine that topic at least came up when you're talking about heart failure. And so that's VA ECMO. So in this case, we're taking blood out of the venous system and then returning it with a great deal of pressure into the arterial system to both oxygenate that blood and to provide the perfusion to critical organs. And this is the cardio help, which is a common pump and console for this purpose. That has, this is your oxygenator. These are your cannulas. You have to have both, drainage and return cannulas. And these can get very large in size, as I think some of you realize. And oftentimes in ECMO, the limiting factor is getting that access, particularly on the arterial side, and particularly when somebody is in cardiac arrest. So the ultimate of this, of providing extracorporeal support, is in the cardiac arrest setting, and that's when we call it eCPR. So just to make sure we're all on the same page for some terminology. So why do we do eCPR? You guys have an eCPR program, and lots of institutions are going this direction. Albuquerque, which is a much smaller place than Houston, we now have 2 centers that do eCPR, and there's a third system that wants to come online. So why all the focus on eCPR? And I think this paper and this graph kind of says it better than anything else. And there's different numbers you'll see in different places, and this is like kind of looking at all comers versus you can look at it you can break it out, of course, by presenting rhythm and all sorts of other factors. But and you will look at good neurologic outcome. And depending on the system you're in, and depending on which patient population you look at, you're going to see different percentages over here. But one thing you'll consistently see is that over time, right, we all know this, over time, your chance of survival drops off fairly substantially. And you will get to a point where the chance of a good neurologic outcome drops definitely below 2% and then drops below 1%. And this starts becoming, and in this study you can see around 20 minutes, we've dropped clearly below 1% chance of a good outcome. And this is the kind of numbers and things that we look at a lot of times when we're making decisions to terminate resuscitation. We're rarely, now there may be a few exceptions in the hospital setting, but we're rarely, when we look at patients who are being transported to the emergency department for this or we're going out to them, we are not getting people on pump before this point in time. So the whole premise of this paper was sort of about when should you look at these other aggressive interventions. And I think, so one of the important points here is when we're putting people on eCPR, they would otherwise have essentially a 0% chance of a good neurologic outcome. And these are the patients that otherwise we would be terminating resuscitation. Yet we can take that population, depending on a lot of factors, depending on their presenting rhythm, and depending on bystander CPR and the quality of that and all of those things, and we can do tremendous things for their outcomes. So this is the Paris experience, and basically, and slightly different way that Lionel sets up his slides here, but if you went from a survival of about, if you had patients who didn't meet their criteria and didn't get eCPR, patients who met the criteria but didn't get eCPR, and the patients who met the criteria and did get eCPR, look at how that survival, neurologically intact, jumps up. And so it's pretty tremendous. Our own experience at UNM, we found that if we just look at the green is our eCPR, and this is, this is going back a few years, our numbers would be a little bit interesting through COVID, since we really shut down a lot of our eCPR program. But you can see survival over here, pretty dramatic survival for eCPR. These are patients who otherwise would have been basically it would have been a termination of resuscitation. So it's also important when you think about what are the risks of this. Well, the alternative is they're dead, right? So it really makes it a lot easier to look at that risk-benefit calculation, because we are just, now, if you're in a place where you can get to somebody and get somebody on in a hospital who already has sheaths in, and all of a sudden, you can get them on pump in, 3 to 5 minutes, that's different, but that's a rare scenario. Now, this is data out of Minneapolis. Some people are familiar with the arrest trial, and just looking at the difference in survival. This wasn't a very big study, but it was actually stopped early because of a clear benefit to the intervention group. But you can see huge difference in survival versus standard ACLS. So that's why we do eCPR, and most places that are doing this are finding that their eCPR survival in the right candidates, right, and you can make this look as good as you want depending on how you hone down the right candidates, but is going to be, 20 to 40% neurologically intact survival. And of course, the highest numbers, VFib arrest, witnessed, bystander CPR, quicker time to get somebody on, right? We all know that. So the question then would be, so that's like kind of why we look at eCPR. Then why would we look at doing pre-hospital eCPR? Because if we're already getting these kind of numbers on the hospital-based programs, what's the advantage of going pre-hospital? And of course, it comes down to time. And this is, I'm sure, the same discussions you guys were having about a stroke ambulance. And a lot of this is time that I don't think that everybody always living in the hospital thinks about. And so there's some EMS people in the room who live these kind of numbers and the timeline, but in general, most places want to get people on pump within 60 minutes. That's the usual number that's quoted from most ECMO programs, is on pump 60 minutes from collapse. Now, of course, 30 minutes is better than 45 minutes is better than 60. And some places, they're extending this to 75 minutes. And of course, a little bit depends. We're doing a lot of hypothermia cases in New Mexico, and of course, that's a different timeline. And if you have stuttering arrests, we debate how the clock is being reset. But in general, 60 minutes from the point of collapse. And the procedure itself takes a certain amount of time, depending on both the expertise and experience of the cannulation team, but also some system factors that go into that, and the body habitus and where you do this. Are you doing this in the cath lab with fluoroscopy? Are you doing this in the back of an ambulance? Where are you doing this? So there's a number of factors, but outside of the outlier of Dr. Iannopoulos in Minneapolis, generally people are looking around a 15-minute goal for getting that procedure done. And sometimes it can absolutely take longer than that, 20 plus minutes, and sometimes 30 minutes, depending on, again, a lot of factors. So you have to have the patient in the hospital. We've now set a criteria for our center, 30 minutes from the point of collapse to arrive in the emergency department door, knowing that there's always going to be a little fudge factor of people kind of optimistically estimating their transport time. But you have to think about what has to happen in that 30 minutes. So if you're doing hospital-based eCPR, in that 30 minutes, a patient has to collapse, right? You need a customer. Somebody has to call 911. That call in most systems is processed by a law enforcement dispatcher first, recognizes it's a medical call without scene safety issues, transfers to an EMS dispatcher, who then recognizes that this is a cardiac arrest, has to go through some process that's different in every system to actually activate the crews that are going to respond to that cardiac arrest. Those resources have to, if they're station-based, have to leave the station. They have to drive. And I recognize there's this thing here called traffic, I've noticed, right? I haven't been here that long. So you have to get to the incident, but pulling up in front is not really solve your problem, right? So now you have to access the patient in whatever structure they're in, find them. So you have to find the patient in the back corner in the bathroom. Then you have to start ACLS because, as we said, ECMO is great, ROSC is better. We can't be focused from the outset on eCPR. So we have to start our cardiac arrest resuscitation. How long that goes that's a great source of debate even in our system, but we think that in general there's at least 10 minutes of time that are going to be spent on that project. At least. Plus, in that time, you're expecting your crews to do a resuscitation, do it really well, and identify somebody who's a potential eCPR candidate. Then that patient, in the midst of running a resuscitation, has to be packaged for transport. So now you have to make sure that all your lines and devices are secure. You have to move them with a mechanical CPR device in place. Then you have to get them to the ambulance. You have to load them and people. You have to drive to your center. Most places you then have to back into a parking place, right? Maybe wait for somebody else to pull out. Back into a parking place, unload, and get inside to whatever room that handoff is going to happen. That's a lot to have happen in 30 minutes, which is what we discovered very quickly. This was our first transport for eCPR Chick-fil-A, that's where all things happen start, right? So this is Gibson in Gibson Boulevard Southeast in Albuquerque. There's a Chick-fil-A there. It just so happens there's also a fire station conveniently like right there, Fire Station 2. And this was a cardiac arrest. We didn't have a system in place yet to do transport for eCPR. We had an eCPR program in the hospital, but in the ER, and it was fairly new, but we weren't doing transport for this purpose. I was on scene of this cardiac arrest, recognized a potential candidate, and really the drive time to the university, 12 minutes. And even in that situation, now granted that was before we had really protocolized the whole system, we rolled into the emergency department already past our 30-minute window. Not by much, but it was past it. And then the case that really prompted the entire development of our pre-hospital program was this case, which was a very unfortunate case of a young public safety member known. He wasn't personally known to me, but his family was known to me. I was also on scene of this arrest, just happened to be, I lived just kind of north of that. I was on my way home, heard this arrest, went to the scene, immediately recognized an outstanding eCPR candidate, and there was absolutely no way, and this was actually, I was on my way home, so it was kind of traffic time, and so this was 22 minutes under absolutely ideal conditions on this particular time with traffic. It probably would have taken drive time at least 30 minutes. So by the time we were on scene and recognized that this patient was a great candidate, it was outside the window. And I had to terminate that resuscitation on scene with his wife and young child in the back bedroom and other members of the public safety community that I knew personally on scene, knowing that this guy was a phenomenal eCPR candidate. He met all the other criteria. So this was the one that really got us together saying, okay, we know they're doing this in Paris. We've got to figure out a way to do this. And the other study that's worth mentioning on this is a very recent study. We just did it as our EMS Journal Club article last week, in fact. But this is out of Prague. And this was transport for eCPR versus standard care. So this wasn't pre-hospital ECMO. But now, interestingly, this study, I mean, they have, if you want to have a cardiac arrest, have it in Prague. Okay? The reason that they didn't meet power in this study was because their baseline survival in the standard therapy group was over 20%, right? So it's pretty hard to compete with that when your baseline, and that's higher than they predicted it would be, which is kind of that classic Hawthorne effect. They had this study and all of a sudden things were just worked so well. But, you know, they still found that there was, I mean, if you look at the actual numbers here, some of it isn't statistically significant, but there was still, even there, and some of these patients got on pump after 60 minutes. Quite a few patients didn't even meet their 60-minute cutoff. And if you look at the survival difference, it's fairly dramatically different. At 30 days, neurological recovery occurred in 38 patients in the ECMO group, so 30%, and 18.2% in the standard group. And then all comers at some point, it was in the, you see the 22% group. So even with that baseline that high, they were able to show a benefit for transport. But it's a very different size system, and you all have a very different size system than we have. Because what we did, and I'm sure you guys have kind of done the same kind of things, maybe formally or informally, but one of our fellows a couple years ago, classmate of Amanda's, did a study basically geomapping the entire city of Albuquerque, putting in standard transport times, and we just kind of published, this just came out, standard transport times calculated off mapping software, and we could plug in, this was actually the work that went in before the actual paper, but we could plug in all sorts of different variables, like how long were we going to be on scene, how long was the cannulation going to take, all those different things, the variables. But basically, all the dots are the city of Albuquerque. And if you're a blue dot, then we could get you, using those variables, we could get you on pump if we transport you to the hospital intra-arrest. That's not a lot of dots. And of course, the other hospital that does eCPR in our system is basically right next door to us. You guys understand how that works, right? So it's not like we're geographically dispersed. The yellow dots are dots that if we simultaneously dispatched and went to the scene, these were the ECMO candidates. And the red dot, which is unfortunately very close to where I live, the red dot is where nothing would work. So it's not much. So most of the city, now again, you could plug in all sorts of different variables and see different outcomes, but we realized very quickly that if we were going to get to the city and get to the population, we had to go to them, which is what we did. And basically the way our system started is not that dissimilar to things that you all have in place here. So we first had a physician field response program. It's very hard to do pre-hospital ECMO if nobody in the field has ever seen a physician out there and has a working relationship and everybody understands everybody, and that's a two-way road. We already respond, depending on the time of the year and how active the fellows are. Not everybody is as active as Amanda, but we generally are on scene of about 20% of the cardiac arrests in our system. So that's already part of the deal. Then we started our hospital adult ECMO program, which happens to be under emergency medicine critical care, which is a unique setup. Then we started hospital-based eCPR. And the same time we were doing hospital-based eCPR, our flight program started doing ECMO transport, mostly to take people out of state for transplant. So we started getting more familiarity with the team, getting familiarity with leaving the hospital. Then we started our ED eCPR program, and around the same time as that, we started going off-site to do cannulations at other hospitals. So again, we're working towards getting our cannulation team comfortable leaving the hospital. About the same time, I started our pre-hospital TEE program, and then it was down here that we actually started transporting people to the ER specifically for eCPR. Up here, it was somebody who coded in the ER or coded on the way. This was actually protocolized transport for this purpose. That's when we actually started planning, based on the case that I talked about, our ECMO program, and then only after all that did we start our program. You all also have a lot of those things, or if not all of them, in place, which again is very different when I talk to people in other groups who kind of can't get past step one, and then, let alone other steps. So the things that you have to have in place, in my mind, to have an ECMO program are these. So you have to have a sophisticated EMS system. If you don't, that would be the place to start. You have to have leadership both on the hospital side and the EMS side that is open to new ideas. Our system just embraced this amazingly. You have to have, in my mind, a component of field docs already. You have to have a close relationship between EMS and the hospital. You have to have providers on all ends that are open to doing things a different way. In my mind, I didn't think we could wait for perfect. I could design a perfect system, and I'll show you one in a few minutes, but we couldn't wait for that. So we just did the best we could because we knew the alternative was we're just terminating resuscitation on all of these people. So there was nowhere to go but up. You have to have a hospital-based eCPR program, right? Because you can't just show up with a patient on pump, just kind of like, hey, surprise. And you have to have cannulators that are willing to go out in the field. And that can be a lot of different models, right? And, who does the cannulation in every system is very different, whether that is EM, whether that is critical care, whether that is anesthesia, whether that is interventional cardiology, whether that is vascular surgery. It can look lots of different ways, but you have to have people that are willing to leave the hospital and take some risk, but only for their metrics. It's the only thing that is at risk is the metric, right? Is like, well, if I put some people on and they don't survive, they can't, how's that going to look for my numbers? So we felt like we had all of those things in place, so we were sort of obligated to do this. So then comes the operational challenge. And pre-hospital ECMO is really about logistics, like much of what we do in EMS. It's a logistical problem, much more than it is a clinical problem. And I can show you how we set it up, and then I can show you how some other places set it up. So what we did, So we decided that we didn't have, okay, so first of all, just to be clear, if you don't realize this, New Mexico is the poorest state of the union, okay? We are 50 for 50, right? You have to be, you have to be good at something. So we didn't exactly have a budget to work with. So we basically took, and I'll show you the ambulance, a conventional ambulance, and we did minimal modification, and we did it ourselves. We literally sketched out the modification on a napkin. We did some of the work ourselves, and we had some guys at the fire department who were very technically savvy to help with some of those pieces. Then what we decided to do was locate our ECMO unit at the fire station that's right by our university hospital. And then the plan, at least as it started, changed a little bit. Now, we also focused by design on a very small group of docs. So a very small group of cannulators and a very small group of EMS physicians to kind of set ourselves up for success. But that also, the trade-off was really limited our availability and our numbers. But the plan was you pick up the cannulator at the bus stop in front of the hospital. I don't know about your bus stop in front of the hospital and ours. Sometimes it's a little questionable who you're going to pick up. And some of our docs on call look a lot like the patients that were just handed scrubs to go home. So there was a few touchy situations, but we were able to get the cannulator, and we started with 3 docs, just 3 of our cannulators, 2 EM critical care, 1 trauma vascular surgeon, and now we've expanded to 1 additional doc who's medicine critical care. And then this is all based on simultaneous dispatch. It doesn't work if you wait till somebody gets on scene and identifies your candidate, because in that case, then they probably might as well just package up and drive to the hospital. So maybe, maybe not. I mean, we actually had one of our cases that actually worked out this way, and the times were still amazing. But in general, we based this on simultaneously dispatch, which means your dispatchers, in addition to recognizing a cardiac arrest, which, depending on how much time you may have spent or hearing calls, is not always as easy as you might think, then has to decide who is a likely eCPR candidate based upon, I'll show you our inclusion exclusion criteria in a second, which can be very hard to determine. Right, you can't get it right all the time in the center, but we didn't want to be sending the team out constantly for cases that weren't going to be high yield. So that, so our dispatchers did an amazing job of that. And then the way with the simultaneous dispatch, when that happened, the local system, so for that district, you get a paramedic rescue, you get a paramedic transport ambulance, you get a pumper, and you get a supervisor and an EMS physician responding to the scene, and ECMO 1 picking up the cannulator and responding to the scene. So there's a lot of resources front-loaded, which is typical of fire EMS. We front-load and cancel as needed. We did a few things that are a little unique, which I'll show you. We load patients into the ambulance feet first, and I'll kind of show you in a second why we did that. And we chose to perform all the cannulations inside our ambulance, which is different from what a lot of the European models do. So that was our decision we wanted a secure location, we wanted some privacy. We didn't think that the city of Albuquerque was ready and mature enough that they could handle this happening on the side of the road or in somebody's living room. That may not be a fair assessment, but that's the decision we made. One of the things that we also did that was very unique is we trained our firefighters to be surgical first assist. So we only have the room in the back of our ambulance. I mean, sometimes we've had 5 or 6 of us on scene as cannulators. And that's great. We can all stand there and do stuff outside and, talk and give each other high fives, but there's room for 2 people, as I'll show you in a second. And that is a cannulator, very experienced, and a firefighter. And they stay within their EMS scope of practice, but they are trained to be the first assist in the procedure. And then the crazy thing that we do is that we don't actually put people on the pump in the field. And this is a whole kind of separate discussion, but for a variety of reasons, we actually, so if you're familiar with ECMO, or if you're not familiar, I should say, if you're not familiar with ECMO, every ECMO machine, in the event of a power failure, has a little hand crank. And turns out the hand crank works really well. In fact, the hand crank costs $5,000. So it is a fine-tuned piece of machinery in and of itself. And we actually use hand crank only until we get to the hospital. And some of this was a cost issue. So there's some training, logistic issues, which it allowed us to use a cheaper circuit than the cardio help circuit, which was important for us for cost. But we also, this came out of, we had a couple incidents in transport where we did have some power failures, and we ended up hand cranking people for quite a while, and they did fine. And so we're like, we realized that the backup actually could be primary. I don't expect, you know, we're the only place that I'm aware of that's using that particular variant. All right, so in terms of our inclusion exclusion criteria, these aren't, there we go. These are not unique. I mean, people can debate all small details in this for sure, but we chose 18 to 75. Witnessed arrest, we changed that a little bit with time. We wanted witness arrest and bystander CPR, but we decided if somebody was in a course VFib on arrival, that was probably a proxy measure for relatively short downtime. End tidal CO2 greater than 10. The initial rhythm, anything but asystole we would consider. Now, we do a lot of pre-hospital cardiac ultrasound. All of our paramedic supervisors in our system do cardiac ultrasound. I think you guys are doing something similar here. All of the EMS physicians have ultrasound. So the PEA patients, it was really dependent on whether there was good cardiac activity or not. And then we would accept secondary asystole. So if they were shocked into asystole, that was okay. And then the exclusion are the ones that are much harder to determine, as you can imagine, over the radio. Well, of course, you don't know what the rhythm is, but significant comorbidities. And this, for us, is the big one here, right? And probably in a lot of systems, right? We see so many overdoses that so many of our young people that are arresting from overdoses, and that we don't want to be sending the unit for just overdose after overdose after overdose. Our dispatchers are amazingly good at teasing that out. This is what our actual EMS treatment guideline looks like, and it kind of talks about, you know, recognizing a candidate. Is ECMO 1 available, yes or no? If we're, you know, if it is yes, can you clearly be at the hospital, one of the two centers, within 30 minutes of collapse? And if yes, then we're going to treat this in general as an ECMO alert and transport, but in all other cases, then we would activate ECMO. And our, you know, this looks very sophisticated. So this is how it actually worked on a day-to-day basis, right? It was text messages, right? I have so many of these on my phone, but every single day I would text the cannulators, and I would text the paramedic supervisor for the city. I'm like, do we have somebody here? Are you guys good? Are you guys good? Yes. And then we would send out an alert to everybody and say, we're good to go, yes or no, during what hours, and that's how sophisticated it was. I mean, this is literally, Todd's first for cannulators, I'm first for the EMS doc, so then, you know, so that's how sophisticated it was. But it actually worked quite well just to coordinate. And eventually the one thing we added over time, and you can see there's a lot of people on the ECMO team alert, so a lot of people would show up on scene in the team for these. We usually, I think the minimum we had on scene was 3 physicians, but I think we had as many as 5 or 6 for our handful of cannulations. So this is our very fancy ECMO unit, right? This was basically a reserve unit that nobody in the city wanted to drive. In fact, the air conditioner didn't work, which took some, we finally got the air conditioner fixed. So this is the unit. Nothing particularly fancy. And kind of show you a few pictures of how this works. So this is training. This is Fire Station 3. This is just us at literally the kitchen table in the fire station doing a wet lab. This is our, at the time he was the EMS battalion chief. Now he's the deputy chief over EMS. Next to him is one of our EMS shift supervisors. Next to him is Dr. Marinaro, my partner in crime, who runs our adult ECMO team and was one of my residents a million years ago. And then the next over is one of our fellows at the time, and then the team, and just, this is it. And we had to do these trainings, as you can imagine, for every shift. And then you kind of go through and make sure that everybody was familiar. This was one of our simulations. So we ran a lot of simulations, and this is how we kind of figured out this whole feet first loading system, because we wanted our guide wires to be in a sterile environment and our cannulas in a sterile environment, but we also needed to be able to continue running a resuscitation. So we found that if we kept the stretcher the same direction but reverse loaded the patient, this worked really well. I will tell you that it was actually very funny haha in hindsight, but one of our, maybe it was our second case, I don't think it was the first case, I think it was our second case, they were already on an EMS stretcher, but they were conventionally loaded. And then ECMO 1 got there, and we needed to reverse load them, but everybody like turned the stretcher the other way, and they basically moved the patient over and realized that we had moved the patient and they were still in exactly the same configuration. Did you ever see that video like on TikTok where the woman is trying to get her car pump, gas pump lined up next to the pump, and she keeps driving around and can't seem to line up with the gas pump? That was kind of what it reminded me of. We've now mocked that out multiple times, and we have that, so we won't make that same mistake. And then we had to go out to a lot of outlying fire stations and do the same training with them, because it doesn't help if the ECMO team understands everything if the teams that we're going to be interacting with don't. So a lot of simulation time built into this. And this is what the very sophisticated back of ECMO 1 looks like. So we have, again, every system's going to be different. We run all of our codes pretty much on a ventilator. So we had a ventilator there. We're very checklist driven. We had a driver checklist. We had the doc checklist. We had the supervisor checklist. Right up there is where we had our groin preps set, so that, because we try to get somebody trauma naked and prepped before they roll into the back of the unit. Ultrasound is hanging from the ceiling on a bungee cord, which worked out very well for us. Over here are drugs that we just needed immediately available. We've since added pumps back here that are just mounted right here, because everybody automatically goes on an epi drip. Everybody gets heparin, of course. We also, the docs are carrying blood products, so we have that available, because we usually end up giving these patients volume. And so basically, we reverse load the patient in here. The cannulation team is inside, two people, right? Maybe a third person ready. Basically, they're gloved and ready. We roll the patient prepped in, and the canyon. So we're on the tailboard doing the rest of the ongoing resuscitation. So we very quickly realized that we needed a tent. And it was actually our fire colleagues that realized that an easy up tent would solve all of our problems. And the fourth case that we did was in a absolute monsoon downpour in the Costco parking lot. And had we not had that tent, I was still drenched. I can't even imagine. So that worked out very well. A couple little details that are fun. So Sandeep Guliani, who is our trauma vascular surgeon, he created the 9-layer bean dip. And that is his claim to fame. He wants to be associated with the 9-layer bean dip. But basically, and now we have these, actually, we've worked with the manufacturer, and we actually have our kits come, all of our ECMO packs come packaged in this manner. But basically, since our first assists are not doing this very often, we wanted it very easy for them to know that the first things they need are on top, go to the next layer, right? Just go to the next layer as you work through the procedure. I mean, they're fairly sophisticated, but we didn't want to, just like, I need an Amplats. It's like, okay, it's everything is right there in the order. The docs that we chose for this, I will tell you, would never, never raise their voice about anything, right? We pick people that you can't rattle. This is our setup. So we took out the captain's seat and used, well, actually I didn't pay it. We moved the captain's seat back and used the original mount for the captain's seat to mount this table that we actually manufactured that opens and kind of folds. And we had our little tower where we mount our oxygenator, and there's the hand crank. This becomes a sterile area for work. And everybody that you're not standing up, you are kind of reaching across off and we don't have access in this particular rescue to both sides of the patient. We have access to one side, so talk about limitations, but you can make it work. Here's what the workflow looks like. I think we've kind of talked about all that, but the key to this is front load, simultaneous dispatch, and a lot of opportunities to cancel as additional information becomes available. I don't know how these move this way, but this kind of shows you what some of our checklists look like. This particular checklist is the doc. This is the Ems Doc Checklist. Actually, the EMS supervisors, paramedic supervisors use the same checklist. So I'm usually looking at that on my, before, on my way to a call, confirming a candidate, making sure we have access. If we have TE available and we have time, that goes in early. A lot of it is parking and logistics. Where are we going to park the ECMO unit? How are we going to rendezvous and get the patient from their apartment to the ECMO unit? We don't want to be sitting there on the curb for too long, so a lot of coordination happens. We use a TAC channel for all of these. We put everybody on a mega mover. We have found that that works fantastic for us. We do this reverse load that I talked about. One of the things we found out very early on is if we like humeral IOs, but there were some patients that had tibial IOs. And then if you can imagine if somebody is reverse loaded and there's a cannulation drape here and you're at the head, you can't get to the IO. And so little things like making sure you have easy access to that. We can put in additional IOs. We can put in IJ lines, if we need to. Constant communication between the units, just to make sure everybody's on the same page. The EMS doc is usually responsible for getting consent if there is a family member on scene. We don't do a signed consent. We do a verbal consent, which is the same thing we do in the ER. But we do try to talk to family if they're there. And then trauma naked from the groin down, prep the groins, and in they roll. This is a couple pictures from an actual case. So picture on the left, you can see there's the rescue in the back. That was the first responding rescue. You can see ECMO 1 is backed into the space. That's my truck next to them there. That's the TE box that's on the ground. This is that easy up tent that has saved us. So once that goes up, we have privacy and we can keep the back doors open and we have environmental protection for the group that's running the resuscitation from the tailboard. This is one of our cases. Actually, this was somebody took the picture. I think one of our fellows took the picture on the way to the hospital. And that, you can see that's one of our firefighters after the procedure, hand cranking. Keep it at 4,000 RPMs or whatever we decide that we need. You can see some nice differential oxygenated, deoxygenated blood there. And you can see a cannulator that learned their lesson about gowning up completely for that procedure. And then this also shows you, this is a different case, but this also, that's one of our firefighter paramedics who's now one of our paramedic supervisors for the city as first assist on an actual case. So he is feeding dilators in that point. He's handing dilators over, feeding them over the wire. He doesn't put the dilator in, so he's staying within his scope of practice, but he has to know, kind of all the steps to the procedure. And then I'm proud that we have fairly good monitoring of these patients. I like to say we really are bringing the same standard of care to the patient. So this shows you we have the ventilator there, we have the flow meter there, we have cerebral oximetry there, and for our A lines, we use and actually published on using the little compass manometers. So we put in a separate A line and use the manometer until we get to the hospital. Saves us, that's pretty quick and easy. That's something that I carry in my flight bag, and I love these things. They're a few $100s, but in the big scheme of things, not that expensive. So we have A line. The only trouble we've ever had with those is not trusting them, right? We had at least one case where clearly the map is higher than 30. And this thing was spot on, and we were behind the game. And then this is, that's my bald head, and that's, this is TE from the tailboard. So this was during cannulation on a case. So we don't require TEE, but it's certainly, it makes everybody feel better that we have wires in the right place. That's our primary purpose. There's a lot of other benefits. And that was our first case that we published, the first in the Western Hemisphere. And we have done, sadly, 4 cases. We have the logistics of this worked really well. I was amazed how well we debriefed every case you could imagine, on and on and on. And we tweaked things each time, but the logistics really worked. And we had cannulation times. Our last cannulation time, I think, was into the back of the rescue. I want to say we hit 11 minutes cannulation. It's almost faster in the back of the rescue than it is in the hospital. Less hands. I got to tell you, it's just two people quietly working. It's amazing how well it goes, as opposed to the general chaos that we have in the hospital, and there's all the learners and all of us. Everybody wants to have a piece of the pie. So we haven't done a lot of cases. COVID hit, we shut down for COVID, we restarted, and then Delta hit, and we shut down again. And now we're right in the process of ramping back up and doing all of our training to restart, because in the process, we have a lot of promotions and retirements, and now we have to retrain a whole bunch of people on how to do this. Some of the challenges that we've found, if you're not 24/7, it's really hard to have everybody thinking about this. And I don't know if your stroke ambulance was 24/7 or not, if you had the same issue, but it's just, you have to really be on top of it if that's the case. Early cancellation was almost too much of a problem, because the way we initially told people was, hey, we're sending a lot of resources, so if you have VFib and you convert, cancel the team. That was a mistake. On our second case, they did exactly what they were supposed to do. They had a VFib arrest. They canceled the response. I continued into the scene anyway, and of course the patient went back into VFib 2 more times, and by the time I turned the ECMO unit around and we got on scene, we probably lost 15 or 20 minutes in our cannulation time, unfortunately. One case, embarrassingly, little things like the ECMO unit isn't used for anything else. So you have to make sure it gets checked and all those things. We quickly realized there was no oxygen in the onboard oxygen unit. It's like, yeah, we had a lot of rescues on scene and other oxygen, but it's like, okay, now we've gotten better at checking that unit. Handoff at the hospital, right? You can't just show up at the hospital with this patient on pump and expect things to go smoothly if you haven't mocked that up. And so we spent a lot of time with our perfusionists, and our style is we stop in the ER CT scanner and do a head-to-toe CT on everybody. That's just our automatic protocol. And then we try to go straight upstairs to the ICU. In one case, we had to, for bed availability, stop in the ER. But since we do ER eCPR, that didn't freak anybody out. You can imagine low volumes were a big issue for us. Some days we just weren't available. Some days we were available from 8 to 12. It's just, you can imagine we had a very small team, and you felt bad, but if those people if the stars didn't align, we just didn't do it. And as a result, trying to maintain skills, it wasn't so hard for the cannulators, but it was harder for the field crews. Now, fortunately, that station is close to the ER, so we would actually, if they knew there was an ER eCPR happening, they would come over and try to get some exposure in the ER to stay up to date. Real quick, I'll show you just what some other places are doing. So the folks in Paris who really pioneered pre-hospital ECMO, some of you may have seen, they sort of win the backdrop award for ECMO. You can't beat the Louvre for PR for ECMO. I can just imagine blood splattering, So their system is cannulate where they drop, and that's very much the European approach. They also do open cut downs as opposed to ultrasound based and percutaneous, and I think they're the only place really that has that focus, but that's just what they've been doing. They've been playing around with ultrasound based, but that's still their go-to. That's just the way they do it. They're also looking at helicopter-based ECMO, and I'll talk about that again in a second. But they were able to get to more patients, which is interesting. I just a couple weeks ago got back from Holland, went to visit the program over there because I'm trying to figure out how to start helicopter-based ECMO. And they have their system right now. It's a study. It's a very nice research protocol. But the entire country of the Netherlands. 6 of Netherlands would fit in New Mexico, so I don't know how many that means for Texas, or that just might even be Harris County, I don't know. But they have 4 helicopters that cover the entire country. They're all physician, nurse-based staffing. They're all anesthesia intensivists. And they are doing a phase-in, like one base has already started doing ECMO. They've done 15 cases already this way. And then they roll in the next base, and then they're going to eventually roll in all 4 as each one is, a control. So this is Denise. He's really the guy behind this whole program. It was really interesting. We totally geeked out. Like you have to, I went all the way to Rotterdam to like look through bags, but we just thought that was the coolest thing ever to like compare notes on our bags. This is their closet. If you notice, this is their locker room and all their flight jackets. And this is where they would do their sims just to work in confined spaces. So their cannulation model is the flight doc and flight nurse do the cannulations. There's no other resources really that make it to that scene. But they cover in the city, out of the city. They cover their goal is to have the entire country of Holland covered with eCPR. They also do. So again, they do it where the patient drops. They don't relocate because they don't really have a place to relocate to. And they are also an ultrasound-based program. Now, the ultimate, as some of you know, is this. This is not pre-hospital ECMO. Okay, I am unbelievably jealous. I have to say that this picture somehow, when I posted it this way, it's coming out on the screen kind of distorted, so you can't appreciate how big this thing is. Like on the screen is like compressed by 50%, and like this thing is like a full semi long. It is actually a mobile cath lab. Literally, it is a mobile cath lab. They do the cannulation standing up with fluoroscopy. It is identical to doing it in hospital. I am envious beyond. I can't even tell you. But this is not pre-hospital ECMO, right? This is bringing the hospital, they're just relocating the hospital somewhere else. And that's amazing that they have the grant funding to do that. But it's just interesting to see they've done now 2 cases. So the grand total of pre-hospital ECMO, if you count this, is in the Western Hemisphere is now 6 cases. And I'm not even sure, again, this counts, but I am jealous. And I am very curious to see what you all end up deciding to do, because I'm sure that yours will not look identical to any of the others. It shouldn't. Everybody has to kind of make this work for themselves. But I do absolutely believe that pre-hospital ECMO is feasible in the United States. And I do believe that there are patients that if you believe in eCPR, that the only way to get to them is if we go to them. We've mapped that out and we've proven that in our system, that it's just the population that is just geographically close to all those hospitals for us is too small, and we just have to get to more patients. But how you deploy that in a system this size with the hospitals where they have it, that is a logistical challenge that I'm sure your EMS folks are up to, but that is a challenge. So I will stop there and take whatever questions you all have, because that's the fun part.
Well, thank you, Dr. Brody. Thank you for coming. It's enlightening, excellent, really good to hear, especially as we're thinking about trying to do something similar. I'm curious how much you know about the San Diego group, the Zach Schreiner, and my understanding is they're all ED based. They published some pretty compelling, regulations and case studies. So how do they operate? What sets them apart from you?
Well, and we work with them quite a bit. I was just hanging out with those guys in San Diego just a few months ago. They are incredibly envious of our system, and I'm envious of theirs in different ways. I think I could probably, Zach was probably, if his wife would move, he would move to New Mexico because he is so excited about pre-hospital ECMO. Because I think he recognizes the limitations of waiting for people to come to them. But they have a fairly sophisticated ER-based, community ER-based, which is what really sets them apart. They're not a primary academic center. They're a busy, high-performing community hospital that has all EM-based, so not EM intensivist, EM-based cannulation. They have it, and they're the ones that offer started the Reanimate course, and they're very much about having a very structured system to how they set up their cannulations, and they do that very well. But they don't do any pre-hospital at this point.
Quick two-part question. How often are you guys doing ECPR in the ED? And the second piece is, if you were live 24/7, how often do you think you could be doing it in the field?
Well, so the first question, how often are we doing it in the ER? So we just restarted the specific transport to the ER for ECMO after our whole COVID hiatus. We just started a few months ago. I want to say we've done, 6 cases since then. I mean, I did a case my last shift conveniently, but then I hadn't seen one in the week or two prior to that. So it's certainly not every day. There's the days where we've had 2 going at the same time, and then there's the weeks where you have nothing. That's kind of how it goes. In terms of, we have tried to do the numbers and try to figure out what is our maximum catchment for our system. And it just doesn't apply to your system. You just have so many more lives here than we have. That's why I'm looking at helicopter-based, because the geography, there's a lot of rural communities that have more proportionally actual cardiac events, whereas the city is sadly so dominated by overdose events that, but we can't we've looked at rendezvous models, we've looked at different things, and we feel like the best way is probably by air, but how do we operationalize that is tricky. I gotta tell you, the cannulators ask me that all the time. It's like, how many cases are we missing, right? And it's like, did we miss a case today? It's like, well, I don't know. It depends on how you spin it. We don't have in our system, we do not, there is no way that if we were running 24/7, I think we would have a good candidate once a week. You guys probably would have a good candidate, more than once a day. Maybe, I don't know, you guys would know the numbers, but it's just population based. Interestingly, in Netherlands, their cutoff age for their study, this is so painful to me, so painful. Their upper age limit, you have to imagine what a different world they live in, is 50. We're 75. They're 50 because if they looked at the numbers. If they went much higher, they were just going to be running. All the team was going to be doing, and they're responsible for all this other trauma and everything else. They were just going to be an eCPR team. Like, that's all they would do. Very different from us. Yeah.
Question and comment. The question is Albuquerque Fire the only 911 agency for the metropolitan area? And have you, if so, because our county is 5 million people, I think it's compared to the population of all of New Mexico.
By far. Yeah.
Have you heard of, or do you know of any models where many different agencies participate or somehow co-share responsibility for?
Right. So in terms of our system, in the city of Albuquerque, there's Albuquerque Fire as the primary first response. It's all paramedic based, and then Albuquerque Ambulance, which is a not-for-profit contracted transport entity that's also paramedic based, co-respond to all cardiac arrests. And so we work close together. Fire provides the ambulance and the firefighter for that, but on scene, we work very closely with both entities. And we have looked at expanding we have, much like you, we have some areas that have a patchwork of other agencies. However, I think the city wants to just solidify the program a little bit more before we take it other places. But because there is a county island that's very close to the hospital that has a pretty high volume of calls, and we would love to expand it there. It's politics. Yeah, we're working on that, but it's always politics.
So when you say you put your patients in first, did you have to redo your inside of your truck to lock that stretcher in the patient?
No, yeah, so it's a great question. So we actually decided to reverse load the patient on the stretcher so that we didn't have to change anything else. The stretcher still goes in the same way, it locks the same way. The patient is just transported feet first. Not ideal,
Did you
but
put the restraints around on the stretcher?
no, they're still restrained. I mean, we don't, as you can imagine, you know, we don't have the shoulder harness isn't going to work in reverse, but they're still belted. Yeah. Would love to have the space to do it because we looked at the configuration of trying to move the stretcher farther into the ambulance so that we would then have protected space on the end, but then we couldn't run the resuscitation inside. We wouldn't have room to do that. So not ideal. Definitely not ideal. That fits into that category of we just decided that you know, the enemy of good was better and we just had to do it.
Darren, I want to thank you for unbelievable talk. I want to thank you for your leadership and, you know, being having the mindset of being the first through the door. You know you're going to get roughed up a bit, but somebody's got to do that. Just, you know, Stephanie, this is Stephanie Parker. Stephanie actually is the one who operationalized and ran our mobile stroke unit about almost 10 years ago, roughly. So
Nice to have expertise in the house.
Stephanie had to figure all this stuff out, and they were actually the first mobile stroke unit in the country. They, you know, of course, you saw they published their randomized results this last year, which were really positive and terrific. A couple of people I need to kind of recognize, Darren. So, of course, we wouldn't even be talking about this or thinking about this if it wasn't for Dr. Purse and the fire department and our other really phenomenal EMS partners. They're all part of this. Chief Bank, Chief Barrera. So they work with Joe Gill at ESC 48. And so we have unbelievable EMS partners. That was actually the thing that I saw here that made this, it kind of captured my imagination. You know, I actually wrote a state grant to do this 3 years ago, and we're funded to do it. We've had a lot of starts and stops throughout the pandemic, but we're back on the train now. And so we have a whole team of folks that are working on all the logistics to do this. Our model will probably be somewhere between yours and Dimitri's Minneapolis model. I don't think we're going to be doing a hand cranking, but nor will we have the giant ambulance. We're sort of going to be somewhere in between, but we're really excited about that. I also need to introduce Dr. Max Feth. Max, maybe just stand up. Folks won't know you. Max is from Hamburg, Germany, and he is an emergency physician and an EMS physician who's specializing in ECMO. He's doing a special fellowship with the United States Army in San Antonio. So part of our partnership is actually with the Institute for Surgical Research at BAMC in San Antonio. So that's kind of a little bit of partnership. I just really want to recognize our EMS guys because we would never even be contemplating this. So you see, we do have a lot of unique things. We have the mobile stroke team that kind of blazed the path. We have the EMS partnerships. We actually have the HVI expertise. We're we're a platinum HVI Center of Excellence, right? And that's not a small thing. That's like, there's just a couple places in the country that actually do that. And we have a partnership now of our HVI leadership. And so we're really excited about doing this, but you know, you've been fantastic helping us along the way. You know, we called you, about 6, 8, 10 months ago, and you have been really terrific, and we really appreciate it.
Oh, we need more people doing this
Right.
as a community. We really do.
Part of this is breakthroughs are iterative. You know, it's slow going, it's slogging. But we've been, you know, Darren and I and other people have been doing CPR research for about 25 years, and you know, a lot of us believe this is the next thing. You know, we have to optimize our community response, optimize our bystander CPR, our EMS CPR quality, our post-arrest care. But then, what can you actually do on top of that to really improve survival? The other thing we do, by the way, is our team actually runs the cardiac arrest registry for the state of Texas. We collect all the data for the entire state. So, you know, that's another thing that, you know, we're doing in the background. I think you said at the very beginning, eCPR is great, but ROSC is better. And so we can't get distracted by, you know, this. And I think there's a little bit of a risk of teams getting distracted away from the basics. I know Richard thinks about that we have to make sure we're not going to get distracted from what we know really works.
And I think the good thing is there is kind of that Hawthorne effect, and getting back to Zach Shiner and group out in San Diego, one of their theories, and I think it's been borne out, is that as you set up one of these programs, it often makes your basics better because you start kind of protocolizing things and people paying more attention to it. So there's the risk of it going the wrong direction and just totally focused on eCPR, but there's also the potential benefit, which we've seen, because the vast majority of our arrests are not eCPR candidates. But I feel like, for example, in the hospital, we now have an intensivist come down for every cardiac arrest that comes into the ER. And they're responsible, and we line almost every patient. Obviously, there's a few that you're just like, okay, this isn't going anywhere. But we put sheaths in almost everybody. Everybody has arterial access, and everybody has sheaths. But it also means that if it's not an eCPR candidate, then there's residents, that are getting walked through that, or faculty by an intensivist. So people are getting their reps that way, and it's made us much better because now, it's just like the codes run better because we have access on everybody.
It creates some hope. It creates some hope that people will try harder. But anyway, I did recognize Where's Schultz. So Dr. Schultz, Gill, Witkoff, Waller, Luber, and Bakunis. Did I leave anybody else out on the team? These guys have been meeting and working on this actually every 2 weeks for at least the last year and a half, working through all the logistics of this, and they're making really good progress. So we're very optimistic about where we are. We have a ways to go yet, but we're learning from people like you, and we really appreciate you.
Well, we'll be following along closely. You guys will surpass us, I have no doubt, very soon. So,
Dr. First, I didn't know if you wanted to. Your input and leadership is key to all of this. And Dave said to me when we first started talking about this about 2.5 years ago. He said, "Ben, you have to do this. In fact, I need you to do this soon."
So I said yesterday.
Yesterday. Yeah. I mean, who has a medical director that actually has that approach as opposed to what a lot of people have is a very kind of tentative, risk-averse kind of approach. And this we wouldn't even be here talking about this if it wasn't for you.
I don't have a whole lot to say. I think Ben has said a lot, but at a different level of the atmosphere, and kind of going to the mobile stroke unit. If we in emergency medicine don't push the boundaries, why do we come to work? Seriously, we can allow ourselves to get sucked into another rash, another twisted ankle, another this, that, and the other thing. But emergency is in our name. If we are not going to step up and try to attack whatever the next emergency is. So the mobile stroke unit, that was something that those Germans, they got that idea first, dang it. But we're not going to be far behind them, right? And so now Albuquerque freaking got an ECMO machine. We're not going to be far behind them. So anyways, these are, the public counts on us to take risks, and then the public needs to have our back when there's roadblocks. But that's what we got to do.
well said. That's the Twitter quote right there, right?